Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This will be also very helpful to fourth year students and even the person who is going to do a private practice. This topic can be asked very frequently in your oral exams as well as your theory exams, and you will see sometime in your internship or during your private practice. In continuity with the neurology series, today we are going to discuss regarding diplopia. Diplopia means double vision. So person, whenever he looks to one object, if he does not have a single image, instead of that he has got two images, one blurred and one sharp image, he gets a dual vision, and that is labeled as a diplopia. So you can see here, this is a sharp image and this is a blurred image. So this will give rise to what we call as a diplopia. So we'll be talking regarding that particular part. So by definition, double vision in the field of vision. So if two eye are not having a parallel axis, so one eye will give a blurred image and one eye will give a sharp image. The eye with a mild alignment will give a blurred image, and that will give rise to diplopia. The terminology which are very commonly being utilized, we can call pathological or physiological. In physiological, there is no damage to neuronal system, or we call cranial nerves. While in a pathological, most common cause of diplopia is because of the neurogenic etiology. It can be affecting one eye. So in that affected eye, in that eye you will see a double vision, and in a binocular, when both eyes are kept open, you will have a diplopia, and this will be very frequently because of strabismus, or we call squint, or crossed eye. It can be right from the birth, we call congenital, and after birth we call as acquired group. It can be crossed and uncrossed depending upon which direction the image is. So if it is on the same side, it is called uncrossed. If it is opposite side, it is called crossed. Also, the word utilized is exotropic, esotropic. Exo means outside and eso means inside. It can be because of restriction of the eyeball movement. Very commonly, it is with some of the disease, say one of the classical example, exophthalmos or periorbital tumors, etc. It can be in a horizontal field or it can be in a vertical field. So if the eye has got vertical squint, then it will be vertical diplopia, and if the person has got either medial or adductor squint or abductor squint, he will have a horizontal diplopia. So we have already mentioned, depending upon the onset, sudden and gradual, monocular or binocular. Monocular most commonly with cataract or corneal opacity or something in a aqueous humor or something in the vitreous humor, or even if the person is having ectopia lentis or dislocated lens. While binocular Very frequently, it is because of cranial nerve palsy, particularly third, fourth, and sixth cranial nerve palsy. In congenital syndromes like Brown syndromes or Dunant syndromes, also can be because of restriction of the eyeball movement, like in case of a thyroid ophthalmopathy, or we call also in case of exophthalmos, or it may be because of the central damage like multiple sclerosis, or even in a case of a stroke. There is also one word utilized, comitant and non-comitant. If it is in the same direction, there will be decompensated phoria or anatomic, while in all different direction, very commonly in neurogenic, myogenic, or mechanical. Myogenic will be very frequently in a person, say, with myasthenia gravis. So now, if you put the etiology together, depending upon the damage, we can put them into supranuclear group, nuclear group, that is if there is a damage to the nucleus, supranuclear group, that is a damage above the brainstem, internuclear, that is a damage to the different fascicles, we call internuclear ophthalmoplegia. If it is infranuclear, means outside the brainstem, that is infranuclear, or maybe myopathic because of the muscle disorders like myopathy, or maybe because of myasthenia gravis. Restrictive disorders where the eyeball movement is being restricted because of the external compression of the muscles, and maybe because of the defect in the orbit. We already mentioned congenital or acquired, physiological or pathological, monocular or binocular. Most common cause is because of the strabismus, which is very frequently because of any one of these causes. Supranuclear, nuclear, internuclear, infranuclear, any one of these causes can produce strabismus. Even restrictive classical example will be Graves, where you will have exophthalmos. Myopathic will be myasthenia gravis or myopathy. And in a supranuclear variety, you can have a multiple sclerosis, or you can have a damage in a supranuclear part by a tumor or an aneurysm. Some of the monocular causes, classical example, refractive error, astigmatism can produce monocular diplopia. Cornea, corneal opacity, scars, irregular surface, and in the lens, cataract. This will be the most common cause for monocular diplopia, while binocular diplopia most common with third, fourth, or sixth cranial nerve palsy. As far as a myoneural junction is concerned, myasthenia gravis, and muscle involved like myositis, thyroid eye disorder, it is also called as a thyroid ophthalmopathy, or can be because of even exophthalmos, retroorbital tumors, and as far as the orbit is concerned, retroorbital tumors or fracture of orbital bones, etc., can produce diplopia. So third, fourth, sixth cranial nerve palsy, we already mentioned it can be supranuclear, nuclear, or infranuclear. The damage to the brainstem can be because of vascular, can be traumatic, can be neoplastic, can be infection. Also, you can have a damage because of diabetes. Thyroid dysfunction can produce damage to the muscle, extraocular muscle. Myasthenia gravis can also have myoneural junction producing a weakness in the muscle. Multiple sclerosis will produce damage above the brainstem very frequently. Parkinsonism can also produce restriction of the movement because of the increased tone in the muscle. And also because of a long-standing refractive error also you can have a diplopia. So restrictive or mechanical diplopia can be Graves' ophthalmopathy in case of a Brown syndrome, pseudotumors, myositis, orbital mass lesion, orbital trauma, proptosis, anophthalmos, trauma in the orbital region, thyroid ophthalmopathy, and even in a post-surgical part. If the two eyes are not aligned, one eye which is not aligned or mal-aligned will have a blurred image, and the eye which has got a proper alignment will have a sharp image, and this will give rise to diplopia. So in this, if you see this eye is mal-aligned, it is having an adductor squint. So this eye will give rise to what we call as a blurred vision, and this will be as the eye is mal-aligned and towards the nasal side, it will give rise to cross diplopia. Blurred image will be on the inner side. So a person who has got a diplopia, ask the person to look in the direction of the affected muscle, which is paralyzed muscle. Person will have a diplopia because eye cannot move in that direction, and the other eye will have a conjugated movement, will give rise to a sharp image, and that will produce a diplopia. If there is a refractive error like astigmatism, or say there is a corneal opacity, or there is a corneal rough surface, or cataract, they will produce monocular diplopia. Means whenever a person is trying to look at the object with the damaged eye, either cornea or lens or refractive error, he will have a double vision, and that is called monocular diplopia. And when it is because of malalignment, it will be binocular diplopia. So while examining for the diplopia, you should observe for the head posture, whether there is ptosis or not, pupil is involved or not, which are the extraocular muscle which is being affected, examination of the orbital part, then other cranial nerve examination, and systemic examination depending upon the clinical suspicion. If head is turned towards one side, it is very commonly seen in a 6th cranial nerve palsy and 4th cranial nerve palsy, very common. So person will have a head turned to the opposite side very frequently in a person with a 6th cranial nerve palsy, because whenever say if the person has got a right side 6th cranial nerve palsy, so right eye cannot move laterally, so it has been deviated medially, that is adduction. So there will be adductor squint. So when the person wants to look to the right side, lateral rectus is not working, so he will have a diplopia in that field. So to have that particular field of vision, he will turn the head to the right side to have that particular posture. So head will be tilted away from the side of the 4th cranial nerve palsy in case of 4th cranial nerve palsy, where chin will be down and head will be away from the 4th cranial nerve palsy. While in case of a 6th cranial nerve palsy, it will be towards the side of limitation, means towards the side of a damage. So that will be typical posture. While chin will be up in case of a bilateral ptosis, classical example in case of myasthenia gravis, head will be tilted up. This will be some of the posture which will give you an idea. Also in case of Duane syndrome, you will have a head tilted toward the side where there is a limitation. So this will be some of the things which you can make out on just looking at the head posture. If it is unilateral ptosis, it will be more in favor of unilateral 3rd cranial nerve palsy. And if there is a bilateral ptosis, it will be more in favor of myasthenia gravis or bilateral 3rd cranial nerve palsy. If it is a partial ptosis on one side, it will be more in favor of Horner syndrome. So look for the third cranial palsy, myasthenia gravis, etc. Look for the extraocular muscle movement. If superior rectus, inferior rectus, medial rectus and inferior oblique are being paralyzed, unopposed action of superior oblique and lateral rectus will push the eye downwards and outwards. That will give you a classical sign. In case of a third cranial palsy, pupil will be dilated, fixed, and there will be ptosis on the side of the damage. So that will be very peculiar in case of a third cranial palsy. So try to look for the extraocular muscle movement. If one eye movement is being affected, it will be unilateral cranial palsy. Both side movement being affected very frequently in case of myasthenia gravis. You can have a gaze palsy in case of an internuclear ophthalmoplegia or 1.5 syndrome, etc. So try to find out those things. Pupil will be involved very frequently in case of a third cranial palsy. While in case of a Horner syndrome, you will have a pupil dilated. While in a third cranial palsy, in a Horner syndrome, unilateral pupil will be pinpoint. While in a third cranial palsy, on the side of the damage, the pupil will be dilated. So try to look for those findings. As far as the orbital examination is concerned, if there is a proptosis or if there is a lid-leg sign, lid retraction, leg of thalmus, etc., chemosis, those will be the signs of thyrotoxic ophthalmopathy. So look for those findings. And then a complete examination for third, fourth and sixth cranial nerve must be done. So that will be the important part. So good CNS examination including third, fourth and sixth cranial nerve examination is a must. This is the thing what a person will have a vision, that is double vision. Here you can see, so while driving, if a person is having this vision, the chance of accidental injury will increase. And the appearance will be very peculiar, which will have a social behavior disturbances. In a third cranial palsy, we already mentioned you will have a medial rectus, superior rectus, inferior rectus and inferior oblique being affected. You will have a ptosis plus you will have a dilated pupil on that side. And person will have a horizontal diplopia as well as a vertical diplopia, and there will be mydriasis. So when all these findings are together, it goes in favor of third cranial palsy. In fourth cranial palsy, the movement of the superior oblique is affected, and that movement produces downwards and inwards. So while looking in that particular position, the person will have eye moving up and in because of unopposed action of other group of muscles. And because of this, the person will have problem while climbing the staircase and reading. Often difficult to see on oculomotor movement testing. There will be vertical and torsional diplopia, especially on a down gaze. So when a person is trying to look down and in, person will not be able to come down the staircase and reading part. This will be very peculiar in a fourth cranial palsy, and person will move the head to the opposite side and tilt the head so that the axis of both eyeball axis becomes nearly parallel so that he can reduce the amount of diplopia. While in a sixth cranial palsy, the eyeball will not be able to move laterally, so there will be adductor squint, and person will find difficulty in driving and looking at the TV, because he will have diplopia, and person will have particularly diplopia while looking. Here, say in this particular person, there is a medial squint and there is a lateral rectus palsy on the right side. So while looking towards the right side, person will have a diplopia. And to compensate that, person will move the head towards the right side. In internuclear ophthalmoplegia, the person will have a defect in a horizontal gaze. So look for those gaze pulses. In a 1.5 syndrome, on the side of the damage, you will have a lateral rectus palsy with gaze palsy. So that's why it is called 1.5 syndrome. As far as the treatment of diplopia is concerned, you give the treatment so that he can improve walking, he can have 3-dimension vision, he can read, he can drive, and he will have less nausea. This can be done by using Fresnel prism, which will improve to some extent, may help in good number of people, or you can use Blendum patch so that he can have a good vision with a non-affected eye, or he can go for ortho-optic treatment, and that can improve the convergence with ortho-optic treatment. And if it fails, then use the prism in a reading glasses. Once in a while, in a restrictive variety, Botox injection can be utilized, and then maybe surgical intervention may be advised. So in a surgical intervention, you will have the corrective surgery, particularly for the squint, either lengthening or shortening of the muscle, and so that you get both eye parallel axis. So after correction, the diplopia can be reduced. Now diplopia is a symptom, so complication will depend upon the basic etiology, as well as because of diplopia, person finds difficulty in reading, difficulty in writing, even while walking, say particularly while climbing down the staircase or climbing up the staircase, or even while driving. And because of difficulty in vision, because of dual vision, person will find good number of time falls and may have fractures also. Now we'll be looking at a video which will show you what is diplopia and how exactly. Listen then.
Specifically how to break it down to determine the harmful from the harmless and what questions we need to be asking ourselves in
Voice quality is not good, but still we'll try to.
First and foremost, you need
So
to
it
think
can
about
be
the
sudden
onset.
onset or
Is it
gradual
sudden
onset.
or is it gradual? The time course here is very important. When did the patient first start experiencing the symptoms? Is a double vision something that happens that's been happening for some time? For example, when the patient's tired or after reading a book for several hours? Or is it something that happened recently, only a couple of days or hours ago? Or for example, after falling off my bike and hitting my head? In this case, it's sudden that we're more worried about. This is our red flag and it's our warning.
So sudden onset diplopia are usually with red signal. I already mentioned this. Monocular can be cataract, can be opacities, corneal opacities,
And if they're still getting double
and
vision,
ectopia
then this is
lentis.
monocular diplopia. And this can be caused by things such as cataract, media opacity, or even a dislocated lens, ectopus lentis. Or is this binocular cause of diplopia? This is a little bit more serious. So in this case, the binocular cause is our red flag.
Binocular will be red flag because it is because of no palsy or Brown syndrome or Dunant syndrome, thyroid ophthalmopathy, multiple sclerosis or stroke, etc.
Is this comitant or non-comitant diplopia? What do I mean by this? So, are we getting double vision the same in all directions of gaze when we perform motilities? If we are, then we're not as concerned. Okay, so this is our safe category. Essentially what this could potentially mean, this is more likely to be anatomical. A decompensated phoria, something with an accommodative influence, so not as serious as our non-competent strabismus, which is our red flag in this case. So this, when our double vision is different, in different directions of cases, we're concerned this is more.
So whenever you get a diplopia in all the different directions, that is non-committant, very frequently because of neurogenic. Now this is also showing you another video.
Double vision, also known as diplopia, occurs when a person sees a double image, where there should only be one.
You can see two images together.
The images may present themselves
one
side
will
by
be
side,
sharp,
on
one
top
will
of
be
one
blurred.
another, or both. This disorder can impact a person's balance, movement, and ability
While
to
walking,
read.
while maintaining balance, while
If only
reading.
one eye is impacted by diplopia,
If it is one
called
single eye,
double vision.
monocular. If it is
If it impacts both
affecting
eyes,
both
it is
eyes
referred to as
together when
binocular
you are
double
having a
vision.
binocular vision,
Causes
then it
of
is called
monocular double
binocular.
vision may include astigmatism, dry eye,
Most common
keratoconus,
astigmatism,
and
keratoconus,
cataracts, to name a few.
cataract.
Causes of binocular double vision include thyroid dysfunction, aneurysm, diabetes, brain tumors, multiple sclerosis, and head injury, to name a few.
And third, fourth, sixth cranial
Depending on the
palsy.
cause of this disorder, treatments may include eye exercises, specially designed glasses, and surgery.
So I end my lecture here. So I feel this lecture will be very beneficial to you for your oral exams as well as for theory exams. And sometime you will come across a person in your everyday practice. You should be able to differentiate between a monocular and binocular diplopia, whether it is acute or chronic, and whether it is because of neurogenic or non-neurogenic. So that you should be able to differentiate very clearly. If you like this particular lecture, please don't forget to press button like, subscribe, and you can share with your friends. So at the end, thank you for taking out time. I know that your time is valuable, and I appreciate you for spending some of the time with me. See you in next lecture.